We're now going to move to general orthopedics. And in general orthopedics, we're going to begin with some common adult orthopedic injuries. A man who fell from a second-floor window has clinical evidence of fracture of his femur. The vignette gives you a choice of x-rays to order. Okay, here are the rules. If you think a bone is broken, you want to take an x-ray. You need 2 x-rays at 90 degrees to one another. Typically, it is AP and lateral. You need those x-rays to include the joint above and the joint below the bone that is broken. But there may be more. If you know how the injury happened, like in this case, and that tells you that there may be another bone in the same line of force that may have been injured, you may want to look at that one too. Like this one, think of a lumbar spine. Think of compression of the lumbar vertebral bodies as this man fell from the second-story window and landed on his feet. Vignette number 21, while playing football, a college student fractures his clavicle. The point of tenderness is at the junction of the middle and distal thirds of the clavicle. This is a very common injury. This is where it typically happens. This is treated with a figure-of-8 device that the patient wears for 4 to 6 weeks. I might add, if it were a child, you don't even need to treat it. Because the reason we put the figure-of-8 device in the adult is to keep that bone nicely aligned so there is no deformity that would be ugly on that patient. In a child, you don't need to worry about that because a child will remodel that fracture. All right, we move to the next one. A 55-year-old woman falls in the shower and hurts her right shoulder. She shows up in the ER with her arm held close to her body, but rotated outwards as if she were going to shake hands. Look at me now. And you see the way I'm looking here now? This arm is close to my body, but instead of the hand being here, where you would expect somebody to protect an injured arm, it's out here, like she's going to shake hands. This is a very classical finding when we have anterior dislocation of the shoulder. Let me keep reading because we have another very classical finding on this one. She is in pain, will not move the arm from that position. There is numbness in a small area of her shoulder over the deltoid muscle. Now that is axillary nerve damage. So we have an anterior dislocation of the shoulder with axillary nerve damage. You do x-rays and you reduce it. And the next vignette, vignette number 23, gives you a different type of dislocation of the shoulder. After a grand mal seizure, a 32-year-old epileptic notices pain in her right shoulder and she cannot move it. She goes to the nearby doc in a box where she has x-rays and is diagnosed as having a sprain and given pain medication. The next day she still has the same pain and inability to move the arm. She comes to the arm with the arm held close to her body in a normal protective position, not externally rotated. This is posterior dislocation of the shoulder. You should have suspected that from the minute you began reading, because the common type of shoulder dislocation is the anterior one. The posterior one happens when there is uncoordinated contraction of a lot of muscles at the same time. We mentioned that one on the electrical burns as one of the injuries that could follow. Well, here is a similar example. Patient has a grand mal seizure, uncoordinated muscle contractions. And this injury is classical because the standard x-rays, AP and lateral, do not show it. And that's why the diagnosis was missed when she went to an emergency clinic. And so what you need here is x-rays again, but order an axillary view or scapular lateral view to make the proper diagnosis and then reduce it. We move to vignette number 24. An elderly woman with osteoporosis falls on her outstretched hand. She comes in with a deformed and painful wrist that looks like a dinner fork. X-ray shows a dorsally displaced, dorsally angulated fracture of the distal radius and a small non-displaced fracture of the ulnar stylus. This is the famous Colles fracture, which is treated with close reduction and long arm cast. Vignette number 25 and 26 show two injuries that are very similar. During a rowdy demonstration and police crackdown, a young man is hit with a nightstick on his outer forearm that he had raised to protect himself. He's found to have a diaphyseal fracture of the proximal ulna with anterior dislocation of the radial head. This is called a Montigia fracture. And let me read the next, and then we'll talk about the management for both. Vignette 26, another victim of the same melee has a fracture of the distal third of the radius and dorsal dislocation of the distal radioulnar joint. This is called Galeazzi fracture. Both of these are a good illustration of a general principle in orthopedics that I want to bring to your attention. When we have a question on the exam about a broken bone, and it's obvious in the description that that broken bone can be easily manipulated back into position and it will hold a good position after manipulation, then that can be put on a cast, and this is what we call closed reduction. But if you have a severe fracture, multiple fragments, a lot of deformity, a lot of displacement, and it's obvious in the description that this is not something that can be put back together by manipulation and kept there with a cast, then we resort to a surgical intervention, what is called open reduction and internal fixation. So a common little guideline to follow on some of these orthopedic vignettes is simple injuries can be managed with closed reduction. Difficult, bad fractures may need open reduction, internal fixation. And these two are good examples because in both of these, often the broken of the two bones needs the open reduction, internal fixation, whereas typically the dislocated one can just be manipulated, put back into place, and put on a cast. All right, we move now to vignette number 27. A young adult falls on an outstretched hand and comes in complaining of wrist pain. On physical examination, he is distinctly tender to palpation over the anatomic snuff box. AP and lateral x-rays are read as negative. Now, this is a good exam question because you have a negative x-ray reading. And yet an astute clinician knows there is in fact a broken bone because this is classical for a fracture of the scaphoid bone, the carpal navicular bone. If there is no displacement, you may not see it on x-rays. And yet from the clinical findings alone, that pain right there on the anatomic snuff box, the way it happened, you put that on a cast. A couple of weeks later, you'll see the fracture. Now, these fractures are also notorious because if they are displaced, they have a high tendency for non-union, and they need open reduction, internal fixation. Let me read you a vignette that would be an example of that. That will be vignette 28. A young adult falls on an outstretched hand and comes in complaining of wrist pain. On physical examination, he is distinctly tender to palpation over the anatomic snuff box. AP lateral and oblique x-rays show a displaced and angulated fracture of the scaphoid. This man will need open reduction and internal fixation. Otherwise, that is not going to heal properly. We move then to vignette number 29. During a barroom fight, a young man throws a punch at somebody but misses and ends up hitting the wall. He comes in with a swollen and tender right hand. X-rays show fractures of the fourth and fifth metacarpal necks. This is what happens when your fist hits a wall. This is often referred to as a boxer fracture because it happens to boxers too. So typically the fourth or the fifth Metacarpals take the brunt of your anger when you hit a wall or a boxer hits somebody else. Treatment depends on the degree of angulation, displacement, or rotary malalignment. Close reduction and an ulnar gutter splint for the mild ones, and open reduction with a Kirchner wire plate fixation for the bad ones. And now we move to something that is very likely to appear on the exam, because this is a problem that represents not only a huge source of pain and disability and even death, but also a huge expenditure for the medical care system. This is the old man who falls in the nursing home and breaks his hip. Let me read you the vignette. A 77-year-old man falls in the nursing home and hurts his hip. He shows up with the affected leg shortened and externally rotated. And before we go to the x-rays, that particular description of the shortened and externally rotated patient, that is a fractured hip. And you can see a picture right now of the shortened and externally rotated. So you look at that individual and you know that person has a broken hip. But it makes a big difference where the break is. So now we have to look at the x-rays. And let me read then what follows on this vignette 30. X-ray shows that he has a displaced femoral neck fracture. Let's talk about this for a minute. The femoral neck has a very tenuous blood supply. And so the femoral neck, in order to survive, requires both the blood vessels that come through the neck and the blood vessels from the acetabulum. So that a posterior dislocation of the hip or a fracture of the femoral neck have a high likelihood of ending up with a dead femoral head. And so the management for this patient, we don't attempt to put back that thing in place because he's going to die anyway. The management for the patient that we're describing now is take him to the operating room, throw away his own femoral head, and put a metal prosthesis instead. But on the other hand, vignette number 31 now. 77-year-old man falls in the nursing home, hurts his hip. He shows up with the affected leg shortened, externally rotated. X-rays show that he has an intertrochanteric fracture. Now, intertrochanteric fractures, you don't have the problem of the avascular necrosis. So now you can do open reduction and pinning. Immobilization afterwards, though, has a very high probability of ending up with deep venous thrombosis and a pulmonary emboli. So we invariably had to add anticoagulation. I'm going to repeat these. These are important enough to be repeated. We're going to cut away from my face. And let me go then through this decision tree. We start with an elderly person who fell and hurt his hip. And you realize that the affected leg is shortened and externally rotated, either because you're shown the picture or you're told. Then we know that it is a fractured hip, but now we have to look at the x-rays. If the x-rays say displaced femoral neck fracture, the management is replace the femoral head with prosthesis. But on the other hand, if the x-rays say intertrochanteric fracture, then it's open reduction, pinning, and be sure that you include post-op anticoagulation. Okay, we move now to the next vignette. This is vignette number 32. The unrestrained front seat passenger in a car that crashes sustains a closed fracture of a femoral shaft. There are many ways of dealing with a fractured femur, but intramedullary rod fixation is commonly done. So if that answer appears among the choices, it'd be a safe one to pick. But now that we're talking about femoral fractures, let's remind ourselves of other ways in which a femoral fracture could appear on the exam, because they may be more than just a broken bone. And we're going to go through a couple of examples. Vignette number 33. The unrestrained front seat passenger in a car that crashes sustains close, comminuted fractures of both femoral shafts. Shortly after admission, he develops a blood pressure of 80/50, a pulse rate of 110, and a venous pressure of 0. You know, this guy is bleeding somewhere. The rest of his physical examination and X-ray survey, including chest and pelvis, are unremarkable. And sonogram of the abdomen done in DR was likewise negative. Now, where is this guy bleeding? Well, remember, one of the places where you can sequester enough blood to go into shock and not be obvious just by looking at the patient is comminuted bilateral femoral fractures, which this man has. So this man needs those femoral fractures to be treated, and if you were told in the vignette, he also has a closed head injury, an acute epidural hematoma, and he also has a aorta that is cracked in two, and he needs those addressed urgently, and you cannot yet do the bone. Well, then something that would buy you time, and a good answer to pick on the exam is do external fixation. Put a pin above, a pin below where the broken femur is. Connect them on the outside of the patient so the bones are not moving, and that will buy you time until you can take care of the femoral fracture. And vignette number 34 is another reminder of another dimension that a fracture of a long bone can show up with on the exam. The unrestrained front seat passenger in a car that crashes sustains close comminuted fractures of both femoral shafts. 12 hours after admission, he develops disorientation, fever, and scleral petechia. Dyspnea is evident shortly thereafter, at which time blood gases show a PO2 of 60. Now, we have visited this before. Remember this thing? Long bone fractures, a few hours later, respiratory failure, fat embolism. Fat embolism. This patient needs to be put on a respirator. Now we move down to the knee, and I'm going to read two vignettes, 35 and 36. They are going to sound hopelessly confusing to you. And after I have you really confused, I'm going to give you a shortcut, including some screen, words on the screen to point you in the right direction. But let me start with the reading of the two vignettes. A college student is tackled while playing football, and he develops severe knee pain. When examined shortly thereafter, the knee is swollen. You know there is something wrong with his knee, right? And he has pain on direct palpation over the medial aspect of the knee. With the knee flexed at 30 degrees, passive abduction elicits pain in the same area. And the leg can be abducted further out than the normal contralateral leg, and this happens to be the valgus stress test. Let me read you the next one. You see how the two can so easily be confused one with the other. A college student is tackled while playing football. He develops severe knee pain. When examined shortly thereafter, the knee is swollen. He has pain on direct palpation of the lateral aspect of the knee. With the knee flexed at 30 degrees, passive adduction. The previous one had been abduction. This one is adduction. Elicits pain in the same area. The leg can be adducted further out than the normal contralateral leg. And this one is the varus stress test. So one of them is abducted, the other is adducted. One is valgus, one is varus. Now both of these represent injuries to the collateral ligament, either the medial or the lateral. And here is the easiest way to look at it. Let's cut away from my face and go to the words on the screen. So we have trauma to the knee. We have a swollen knee. We have passive either abduction or adduction, eliciting pain. The joint can either be abducted or adducted more than the normal, and this is going to be referred as a valgus or varus test. When you know that this is what the vignette represents, this is an injury to a collateral ligament. Which of the two? The one over which there is pain on direct palpation. So you don't need to remember whether it is a valgus test, the varus test, whether the abduction or the adduction are the ones that are abnormal. You read this whole constellation, you realize this is a collateral ligament that is damaged, and it is the one over which there is pain on direct palpation when you read that vignette. Now we move to the next vignette, vignette number 37. A college student is tackled while playing football, and he develops severe knee swelling and pain. On physical examination, with the knee flexed at 90 degrees, the leg can be pulled anteriorly, like a drawer being opened. A similar finding can be elicited with the knee fixed at 20 degrees by grasping the thigh with one hand and pulling the leg with the other. This is an injury to a cruciate ligament. Very conveniently for our memorization here, if it is the anterior drawer test that is positive, the problem is in the anterior cruciate. And if it is the posterior test that is positive, the problem is in the posterior cruciate. And I'm going to emphasize that and repeat it for you again with one of the screens here. So if you have trauma to the knee, there is a swollen knee and a drawer test is positive, there is an injury to cruciate ligament. If it is the anterior drawer test that is positive, the injury is to the anterior cruciate ligament. If it is a posterior drawer test that is positive, the injury is to the posterior cruciate ligament. Let me have one more vignette that I'm going to read about the knee, and I'm going to backtrack then about management. We're now on vignette number 38. A college athlete injured his knee while playing basketball. He has been to several physicians who have prescribed pain medication and a variety of splints and bandages, but he still has a swollen knee and knee pain. He describes catching and locking that limits his knee motion, and he swears that when his knee is forcefully extended, there is a click in the joint. He has been told that his x-rays are normal. This is a pretty classical description for a meniscal tear. A tear to the meniscus is difficult to diagnose clinically. X-rays will not show it, but the MRI shows them beautifully. An arthroscopic repair is eventually done, trying to save as much meniscus as possible. If you do a complete meniscectomy, you can have then degenerative arthritis later. So what I was going to backtrack is what this vignette already pointed out. Once you have read the vignette where there is an injury to the knee is swelling and it's either the collateral ligament, the cruciate ligament of the meniscus, your best diagnostic test is the MRI. The MRI can show those little structures inside the knee very nicely. We now move to vignette 39. A young recruit complains of localized pain in his tibia after a forced march at boot camp. He is tender to palpation over a very specific point on the bone, but x-rays are normal. Now this is a classic description of a stress fracture. Stress fractures happen with repetitive motion that the individual cannot avoid. Like in this case, a recruit who has to march whether he likes it or not. And he's feeling the pain, but he has to keep on going. Eventually then he shows up like this description. There is a localized spot that physical exam elicits pain. But the interesting thing is that the x-rays are normal, because x-rays do not show a stress fracture until a couple of weeks later. But based simply on the clinical findings, you know that there is a fracture there, and you either pick an answer that says put him in a cast, or pick an answer that goes for non-weight bearing with the help of crutches. In year number 40, a pedestrian is hit by a car. Physical examination shows the leg to be angulated midway between the knee and the ankle. X-rays confirm fractures of the shaft of the tibia and fibula. This used to be a very classical injury because the height of a bumper of a car, if it hit you, would hit you in the lower leg. This is changing now that everybody's driving SUVs, and we're going to see probably different types of injuries. And I often joke with my students that if you get hit by a Hummer, you get a sternal fracture rather than a fracture of the leg. But this is a classic, and typically the management will be casting of those that can be easily reduced, or open reduction internal fixation with intramedullary nailing for those that cannot be aligned properly. Now let's digress for a second from just what's happening to the bone in this vignette we read to something else that could happen in the lower leg with a broken bone. Vignette number 41. A pedestrian is hit by a car. Physical examination shows the leg to be angulated midway between the knee and the ankle. X-rays confirm fractures of the shaft of the tibia and fibula. Satisfactory alignment is achieved and a long leg cast applied. In the ensuing 8 hours, the patient complains of increasing pain. When the cast is removed, the pain persists. The muscle compartments feel tight, and there is excruciating pain with passive extension of the toes. We've talked about this already, and I'm going to keep giving you examples. Let me start at the very top. The two most common places in the body to develop the compartment syndrome are the forearm and the lower leg. Prolonged ischemia followed by reperfusion can do it, but any other kind of trauma can do it. We already used the example of the little girl that had the crushing injury. Here is another example. As a consequence of this fracture, the patient has developed a compartment syndrome. How do you know he has? He has a persistent pain. The pain is getting worse. You examine that leg when you remove the cast, and the muscles feel very tight. And I've introduced in this vignette the most reliable physical finding, that excruciating pain with a passive extension of the toes. So yes, this is a compartment syndrome. Fasciotomies are needed. Now when we're down to the ankle, vignette 42. An out-of-shape, recently divorced 42-year-old man is trying to impress a young woman by challenging her to a game of tennis. In the middle of the game, a loud pop is heard like a gunshot, and the man falls to the ground, clutching his ankle. He limps off the court with pain and swelling in the back of the lower leg, but still able to flex his foot in the plantar position. However, this is not satisfactory. He doesn't have the strength he normally has, so when he seeks medical help the next day, palpation of his Achilles tendon reveals an obvious defect right beneath the skin. Classical presentation with a rupture of the Achilles tendon. It actually could happen to anybody, including well-conditioned athletes, but this is a common presentation. An out-of-shape person putting a kind of a stress on that Achilles tendon that tendon cannot take. We can treat these with surgical repair, or if it's not urgent that the patient be back to activity, he could be put on a cast in the equinus position, which means the foot would be like the foot of a horse, extended like that. Vignette number 43. While running to catch a bus, an old man twists his ankle and falls on his inverted foot. AP lateral and Mortise X-rays show displaced fractures of both malleoli. It's common for both malleoli to break, whether the patient falls inverted or reverted, because one malleolus gets pushed out, the other one gets pulled in, and vice versa. And like we've been talking about in many of these, if these can be easily manipulated, they are not displaced, etc., you could do close reduction. But if it is displaced, like this one said, then you need open reduction and internal fixation. We're going to review a few pictures, some of which we have shown you already, just so that we again have illustrations of common adult orthopedic injuries. The first one that you're looking at right now is a clavicular fracture. You can easily recognize the break on the bone. Here is a distal humeral fracture. Pay attention to this one because eventually we're going to talk about associated neurovascular injuries, and this would be one that could easily entrap the radial nerve. Here is a fracture of the radial head, and here is a very classical fracture of the radius and ulna. And I might point out something while you're looking at this picture. It's very unusual in the forearm and the lower leg for only one of the two bones to be broken and the other one to be absolutely intact. Usually there is a fracture affecting the forearm. Both bones are broken, or one of them is broken and the other is dislocated. And you are seeing here fractures of both the radius and the ulna, which would be a very common situation. Now, this is one that we made a point on the vignettes. You have to rely on your clinical acumen. In this particular one, you can actually see the fracture of the scaphoid. But you might have a vignette, as we pointed out, where the x-rays are read as normal, and yet there is a scaphoid fracture simply based on the clinical findings. This is one that we have talked about, and I believe we even showed it to you as I was talking. This is a famous boxer fracture. This is what happens when you hit the wall with your fist. And you see in this case how it is the fifth metacarpal that suffered the break. And finally, this is a dislocation of a scapholunate. We did not talk about this in one of our vignettes. I'm going to now repeat some of the pictures that were already shown as I was speaking to you about some of the vignettes. Here is another look again at a gentleman that has a shortened extremity with external rotation. And you can recognize immediately that is a fracture of the hip, shortened, externally rotated. And we had already seen this picture of a fracture of the femoral neck displaced. You know that the answer on this one is to replace that femoral head with a prosthesis, not to try to put it back in because it would die. And here is a picture of an MRI showing a tear to the meniscus, something that you would not see on plain X-rays. And this is another picture that is worth looking at more than once, because this shows a posterior dislocation of the knee. And as we go on to the orthopedic subsets that follow, the ones that talk about an orthopedic injury that affects a nearby nerve or vessel, we will show this one again as a type of lesion where your concern is the integrity of the popliteal artery.